Okay, make sure connection is intact, but unstable. Okay.
Okay,
And you got only 10 minutes to present, right? You have to give your presentation in 10 minutes. Okay. That's like exam. You are not round the corner of exam. So we'll be timing you. Right. Timing you for 10 seconds. Are you ready?
okay, sir.
Are you ready?
Yes, sir.
We'll start. Right? Start. Get 10 minutes. I'll tell you when it's off. Right. Okay. Go on.
Okay, sir, my patient is Master Shashi Nimsara, a 5 years and 3 months old boy from Kadavata. The history was taken from his mother, who's educated up to A levels. This was a previously healthy child who presented with fever, rash, and joint pain for 1 month duration. 5 weeks back, the patient has had an initial episode of left-sided ear pain and a purulent discharge with no fever or no hearing impairment, and was treated with oral medication, and the symptoms have settled. 1 week after that episode, that is 4 weeks ago, the mother has noticed a non-itchy pink to red color rash, which was appearing mostly on the bilateral anterior thigh, which did not have a definite shape. It appeared like a cloud. And eventually, the child also has developed fever, and the rash has become more prominent with the fever and disappeared when the fever settled. The rash also appeared on bilateral upper limbs and the abdomen and face. According to mother, the rash was increasing in severity towards the afternoon and it fades away in the evening, which was similar to the fever pattern. The fever was an intermittent low-grade fever, which was documented to be between 100 to 102 degrees Fahrenheit. The mother has given 4 milliliters of paracetamol syrup 6 hourly, which was higher than the recommended dose. The dose she has given is 25 milligrams per kilogram per day. The
25.
fever was most severe in the
How much is
Yes,
it? Dose
she
was?
has
How
given
much?
4 milliliters 6 hourly, sir.
Dose is?
4 milliliters 6 hourly, sir.
Right. So what's the dose? Daily dose was?
Uh, it was 25 milligram per kilogram per day, sir. The boy was 15
So
kilograms, sir.
that is higher dose. Top therapy dose. 25 means normal dose is 50 milligram per kg per day,
15 milligram per.
kg 6 hourly. So it comes 60. Normal dose is 60.
Okay.
This is the top therapy
Yes,
dose.
yes, yes. Okay, sir.
This looks
Yes, sir.
at body.
Yes, yes.
Got it wrong, I think. Your calculation is wrong. How much
Yes.
I was given? Dose was how much?
25 milligram per
How much?
kilogram per day, sir.
No. What's the dose she was given per dose?
4 milliliters 6 hourly, sir.
4 milliliters 6 hourly.
6 hourly. Yes.
So how much does the 1 milliliter contain?
24
5
milligrams.
milliliters contain 24. So that is come to 196 milligrams into 4. So actually, size rate is how much?
15
Size rate
kilograms,
is
sir.
15 kilograms.
15
So what's the normal
kilograms.
dose we recommend? Upper limit of the normal paracetamol
15
dose?
milligram per kilogram.
Per dose,
15
per kg
milligram.
per dose. Per kg per dose,
Yes, sir.
right? So
Yes,
he is
sir.
getting
Yes, sir.
the 15 milligrams. 15 means child should get about 225 milligrams of paracetamol per dose, right?
Yes.
This child for
Yes,
therapeutic
sir.
dose would have been 225 milligram 6 hourly, whereas she has got only
Yes, sir.
around
96.
96 milligram per dose. So she has been given a subtherapeutic
Yes,
dose,
sir. So,
right? Not overdose. Okay.
yes.
Okay. Okay, go on. Sorry.
The fever was mostly severe in the afternoon and in the night. It was not associated with chills and rigors, and the child's activity has been normal between the fever spikes. 1 week after the initial episode, the child also had
So,
joint swelling,
can I interrupt
sudden
you? Can
onset
I interrupt
joints.
you? Hello? Did the fever come down to the baseline before coming it up, or it didn't come down to the baseline?
It came down to the baseline, sir.
Okay, right, good. Okay, go on. Go on. Sorry. Again.
1 week after the initial episode, the patient also had a sudden onset joint swelling, which is first started on the right-sided ankle joint and then progressed to the left-sided ankle joint as well. There was joint pain and swelling. There was no warmth or redness. Then eventually the right-sided wrist joint was also involved. No involvement of small joints, no back pain, neck pain, or buttock pain. The
Sorry,
child had
Mohammed.
joint
Hello. Sorry, what's your name?
Tanya,
Your
sir.
name, please. Right. Okay. Okay, Tanya. What is? Can you tell more about the joint involvement? How bad was the joint pains? How bad were they?
Uh, the patient has a joint stiffness which was more prominent in the morning, sir, and associated with pain where the child could not walk. Child used to limp after he gets out of bed.
Right. Could he bear weight?
And which
Could he bear weight on his
sir,
ankles?
no, sir, he couldn't walk, sir. He
Right.
was finding it difficult to walk.
Right.
And
Did the pain improve with the
those
time?
symptoms had, yes,
Did the
sir, it improved in the afternoon.
right. So when the other ankle joint was involved, was
And
the
he
first joint
was
still involved or
able
settled?
to.
When the left ankle was involved
Uh,
of right joint, was the first ankle
no,
joint
sir,
still
there was. Bilaterally, it was involved, sir.
right?
Still
Continue.
there.
Right. When the wrist joint was involved, was the ankle joint still involved?
Yes, sir.
Okay. Okay. So all three joints are involved at that time. Right. Okay. Go on.
Yes, sir.
Right. Okay.
There was no rash that was scaling off or pitting in the nails. There was no chest pain or shortness of breath. No recurrent upper respiratory tract infections or sore throat. There was no hematuria, no blood and mucus diarrhea. There was no history of trauma. No recurrent infections, bleeding manifestations, or anemic symptoms. There was loss of appetite. No loss of weight or nice sweats, no severe bone pain which had affected the sleep of the child. There was no red lips or red tongues or peeling off of skin in fingers. There was no photosensitive rash over the cheeks and nose, no oral ulcers or frothy urine. Uh, the child was otherwise having a normal functional level. Only during the fever and joint pain, there was functional impairment. There was no reduction in range of movement of the joints or no visual impairment. The child was previously admitted at LRH with symptoms
What did you
with
ask about the
1 week
vision?
of fever.
What did the physical ask about the vision?
Whether there was any impairment in vision, sir, blurring of vision or reduction in vision.
Was any pain in the eyes? Was there difficulty looking at the light?
No, sir.
Did you ask?
No, sir.
Okay, go on.
Yes, sir.
Yeah, go on.
The child was previously admitted to LRH with 1 week of fever and was treated with IV antibiotics for an acute ear infection and was reviewed at the ENT clinic 2 weeks back, but there was no attention given to the joint pain or rash. The symptoms have persisted, and then 1 day prior to admission to our hospital, the symptoms have worsened, and mother was advised to get admitted for further evaluation. After admission, there were blood investigations which were taken. A scan of the abdomen was done and it was normal. Eye referral was done and it was normal. Echo 2D echo was done and ECG was also done, sir. Those were all normal. The child has no significant medical history in the past. The child was born via a normal vaginal delivery with a birth weight of 3 kilograms, no infections in the antenatal period, no perinatal or postnatal complications, and no PBO admissions. The immunization was up to date, sir. Last vaccine was the oral polio fifth dose and DT dose at 5 years, which was on the 7th of September. And the child is awaiting the adult tetanus vaccine. No vaccine related complications and no other extra NIP vaccines were given. The development of the child was age appropriate, the growth was adequate, and the growth has remained throughout median to -1 SD. Currently, the child is going to Montessori and has average performance. In the dietary history, the child was exclusively breastfed for 6 months with complementary feeding starting at 6 months. Now he's on adult diet And the total calorie requirement of the child is 1,450 kilocalories, and the child currently takes 1,108 kilocalories below the requirement, and also has poor dietary habits, which includes biscuits and colored drinking, which is high in refined sugar. And the child does not eat fish, sprats, meats, or egg yolk, and prefers to eat fried food. The child has not undergone any surgeries, no allergies to food, drugs, or plasters, not on routine drugs. There is no family history of arthritis, inflammatory bowel disease, or psoriasis. The child is living with his father, mother, elder sister, and maternal grandmother. The father is working in
Oh, oh,
financial
yeah.
company who's educated up to A level. They have an income of 35,000, which is economical problem. Sister is in grade 6. The nearest hospital is North Colombo Teaching Hospital, which is 10 minutes away from their house. There's no private vehicle. They have to hire a vehicle. They're living in a single storied house, which is situated near the doors. There are no staircases. Um, Child is awaiting for grade 1 admission, sir. They have a squatting pan in their house, which a child finds difficult when the child is having arthritis episodes. The child is not using walking aids. The child also has a poor eye contact with strangers and also his father and teachers, but plays well with his friends. According to mother, the father is very strict, so the child is scared of his father. Father does not take alcohol or does not smoke, and there is no marital disharmony in their family. At home, his child plays well with his sister, and the child is happy at home, and he likes to go to school. There is no school refusal. Um, they are raising hens, cats, and cocks at home, and the child plays occasionally with them. And the mother is very worried about the disease, as he was also admitted at LRH and no diagnosis was given. So she's worried about the child's
Okay, move
disease.
on to examination. Time is up actually. Come on, I interpreted in middle. No, come on, go for the examination findings.
On examination, the child's weight is 15 kilograms, which is between -1 st to -2 st. Height is 106.6 centimeters, between median to -1 st. Weight to height is between -1 st to -2 st, sir.
What does that growth
On
chart
general
say?
examination, the
What does it?
child is
What's
active,
your
well.
interpretation? What's the interpretation of the growth parameters?
So they are normal, sir.
Your weight is between median and -1.
Weight is between -1 to -2, sir. Weight to
Sorry,
height is between -1 to -2 SD.
-1. Right. It is
Normal, sir.
okay. Right, fine. Go on.
On general examination, the child is active well, uh, febrile to touch, not pale, not ecteric, no dysmorphic features. There were no scratch marks. There was a rash which was present on bilateral upper limbs and abdomen. It was a pink blanching rash with indefinite shape, no papules and no elevated edges. There was no strawberry tongue, no cracked lips, no oral ulcers. The throat was normal. There was right-sided cervical lymphadenopathy, no axillary lymphadenopathy, and there was bilateral inguinal lymphadenopathy. No clubbing, no peripheral features of infective endocarditis, and no bilateral ankle edema. On the examination of the joint, at the time of my examination, the joint was not swollen, it was not red, there were no scars. There was no tenderness or warmth.
Movements.
Range of movements in all were normal. Movements were no pain when moving joints. There was no contractures or deformities. The spine was non-tender and the gait was normal. In the abdominal examination, the abdomen was not distended. There was no hepatosplenism. On cardiovascular examination, pulse rate was 112 beats per minute. Blood pressure was 90/60. There was no chest deformity or scars. Apex was palpated in the fourth intercostal space, medial to midclavicular line. Normal character. No trills and no palpable heart sounds. Auscultation. first and second sounds were normal intensity. There was a soft no splitting. There was a soft ejection systolic murmur in the left upper sternal edge, which changed with position. In respiratory system examination, there was vesicular breathing. Air entry was equal bilateral, no crepitations, and no signs of pleural effusion. And
Right,
this
okay.
central nervous system examination was normal, sir.
Right, okay. If I ask you to examine something in CA, what will examine? With history,
Sorry,
where
sir.
will you examine? What will you have, if I ask you to examine some one thing in CNS examination, what will you examine? එකක් කරන්න ගොත් එහෙම some one thing you'll do, what will you do? Related to this condition.
I
Under the
understand.
Okay, anyhow, we'll come to that later. Right. What is your diagnosis or differential diagnosis? Do you have working diagnosis or not?
Systemic onset juvenile idiopathic arthritis is one of my diagnosis, differential diagnosis, sir. And it can also be a reactive arthritis.
Why don't you consider rheumatic arthritis here? Rheumatic fever.
The child does not give a history of sore throat, sir. Sore throat.
That's all. They always give us history of sore throat. Is rheumatic fever? Not necessarily. Most of them they'll have, but not necessarily. What are things that are against rheumatic fever in this history? In the clinical scenario.
The rash, sir. The rash is a
okay, could be
macular
an allergic
rash,
reaction sometimes.
which
Yeah, it is. I'm thinking there are enough things to point out towards JIA, right? Yeah, but right. But one of the most important thing is rheumatic fever, isn't it? Why do you want to make sure that you don't miss rheumatic fever? But JIA and rheumatic fever take both are serious conditions. But your prime concern would be to make sure that you are not missing rheumatic fever. Whereas JIA, even if you miss initially, there is no big harm. Why is that? Why you want to more concern
the
about rheumatic
effect
fever?
on the heart, sir. Carditis can
Yeah,
be a
one can
serious
get
manifestation.
carditis, and what else? Because rheumatic fever can prevent. You can prevent rheumatic fever, whereas rheumatoid arthritis is not a preventable thing. You can controllable only. So with appropriate intervention, you can prevent a recurrence in rheumatic fever. So it's a crime to miss a rheumatic fever rather than missing a JIE, right? So and again, the fatal complication can be there, right? The rheumatic fever, and you can prevent the recurrence easily. So the prime importance is when a child comes with arthritis to make sure it's not rheumatic fever. Right? I agree with you. There are enough features to point towards JIA, but what are the features that are to consider it not as rheumatic fever?
Migrating polyarthritis.
Right? Is there or not in this
Not
child?
there, sir.
What the type of arthritis you get in rheumatic arthritis? What is the type
Involving
of can you describe the
fitting and
arthritis in rheumatic
fleeting.
arthritis? Sorry? Okay, describe it. What is the describe the total nature, entire nature of the arthritis in rheumatic fever. ඔක්කොම again one features ටික.
It's a fleeting and fleeting arthritis, which mainly involves the large joints, sir.
Okay, right. Okay.
Polyarthritis.
Mainly involve large joints, right? Especially weight bearing joints. What are the common joints that usually involved in rheumatic arthritis? What
Knee
are the
joint,
commonly
ankle
involved joints?
joint.
Then ankle joint. It can be involved in wrist and ankles, right? Larger joints, but commonly in ankle and knee and knee and ankle are more common, right? So,
Yes.
what's the degree of arthritis? In a talk about arthritis in rheumatic fever, what is the degree of arthritis you're talking about? Mild, moderate, or severe? Is it a mild arthritis, moderate arthritis?
Mild to moderate, sir.
No,
Mild to
if you want to
moderate.
call it arthritis, no, it's a severe arthritis, right? So we are talking about rheumatic arthritis.
Okay.
Now you have two things. You have arthralgia and arthritis, right? In rheumatic fever,
Yes.
arthritis is a major criteria. Arthralgia is a minor criteria, right? So you have to make sure that what you are talking about is just mild pain in the joint without much restriction of movements, and child can say low limbs, child can bear weight, then it's a minor criteria. Whereas if it is a major criteria, there will be significant pain and loss of function, and child might be not be able to bear the weight. So it's usually severe arthritis, not a mild moderate, right? So rheumatoid arthritis is severe. Then what is what nature of the arthritis? So will there be all 5 features of arthritis in rheumatic fever arthritis? All this rudo, polo, dolo, rheumo, පහක් තියෙනවනේ. Will you see all the 5 features of arthritis in rheumatic arthritis? The joints. The redness, warmth, pain, tenderness, and pain, and loss of function, all those will be there?
Not sure, sir.
Yes, yes, right. So you get all 5, right? So you just should see all the 5 features of arthritis, information to call it arthritis. If it's only pain, then you call it arthralgia, right? So it's important because the criteria is different, right? So it this major criteria, minor criteria depends on the degree. So, and what do you mean by fleeting and fleeting arthritis? What do you mean by the term? What do they mean to you? What do you mean by fleeting and fleeting arthritis?
Fleeting means it's transient, sir. Fleeting is moving from one joint to the other.
Okay, that means the arthritis need move from one joint to the other. And then what happens when it moves from one joint to the joint, previous joint?
The previous joint, the symptoms settle, sir.
Yeah. So once the good. So once the arthritis moves from one joint to another joint, the previous joint becomes normal, right? So because rheumatic arthritis won't cause chronic joint problems. Right? It's very unlikely to cause chronic joint problems in rheumatic arthritis. So in this child, I particularly asked because the one ankle joint was involved and then the next joint was involved while the first joint was still involved. And at one time there were 3 joints involved, which is usually not likely causing rheumatic fever. Right? So that is one thing. And then there should be a fever, usually it is rheumatic fever, right? And so the 2 major things, that is one thing is the rash, and the rash, of course, we can get rash in erythema marginatum, but rash we describe is not erythema marginatum, isn't it? Right. So
yes.
So what are the features in the history and examination? Time is already up. Come on, we'll go on, right? The time is already up. It's already 20 minutes plus. What are the features in this history that is in favor of JIA?
The pattern of rash, sir. Rash appearing with fever and settles with fever.
Okay.
And
what type of rash you
the
get?
The fever also, sir. It's a
what is the characteristic of rash? What is the characteristic of
rash? Maculous salmon pink.
salmon pink ළමයි හම්බ වෙන්නේ නැහැ. salmon pink බලන්න බලාපොරොත්තු වෙනවා. අපේ ළමයි salmon pink නැහැ. හොඳේ. salmon pink පේන්නේ සුදු ළමයින්ගේ. අපේ ළමයින්ගේ it's a erythematous rash, right? In our dark skin children, we don't get the salmon pink rash. So any erythematous rash comes on with fever and fades off with the settling of fever, right? That's one thing. Good. And then the fever, what the fever pattern in this child?
Quotidian fever, sir. 1 fever spike per day, 1 to 2 spikes per day.
And is it in favor of JIA?
Yes, sir.
Yeah. What do you call that type of fever?
Quotidian fever, sir.
Quotidian fever, right? Good. And then what else about the fever in JIA? Degree of fever? High fever, low fever?
High fever.
Yeah, good. High fever, high spiky fever, and it settles and comes down to baseline or not?
Comes to baseline, sir.
Yeah, come to baseline. Good. So it's a very high spiky fever, but twice a day, usually early morning in the evenings, and then in between the fever is normal, and the fever will come down to baseline even without analgesics, antibiotics, right? That's the feature of fever in JIA. So that is in favor of JIA, and again the degree of fever is high, and child will be very ill during that period. And so those are in favor of JIA in this child. Right. So, why did you consider reactive arthritis in this child? Why did you consider reactive arthritis?
The child has had a previous acute otitis media.
සමන එක
So I
මීඩියට
thought,
නෙවෙයි සාමාන්‍යයෙන් upper respiratory infection ගොඩක්ට එන්නේ. But do you expect reactive arthritis to go on for 1 month and involving 3 joints?
no, sir.
Is it unlikely, right? So the
No, sir.
reactive arthritis going on for 1 month is very unlikely. But reactive arthritis is transient thing, and usually monoarthritis. You won't get these systemic features are not there usually with reactive arthritis. So that's a common mistake you all do, because just because you want a differential diagnosis, you come out with a totally irrelevant diagnosis, right? So don't come out with totally irrelevant things just because you want a DD. If you don't have a DD, it's all right. Yeah, you'd have to always have a DD.
Okay, sir.
If the diagnosis is straightforward, there's no point giving a stupid diagnosis just for the sake of giving a different diagnosis. This has I've seen I have seen several times in exams as a you come down with a totally irrelevant thing just because you want a DD. එහෙම කරන්න අවශ්‍යතාවයක් නැහැ. So you say this is type, but this is more likely this is there are enough grounds clinically to say this is JIA. Right, good. So the subtype you said, why do you say this type is systemic onset one? What's the reason?
So the systemic onset, sir. It's an acute
Okay.
illness.
Okay.
And there was lymphadenopathy, sir. Cervical
Okay.
and bilateral.
Go on. I'm challenging you. You can defend yourself, right? Don't hide. Don't think. You had to you are doing all right up to now, right? So you had a challenge. I'm just challenging you. You should have the guts to stand on your feet. So don't get you can argue about, right? So you may be right. So what are things you say is so what are the things that you are telling that?
For systemic onset JIA, sir, favorable features are the patient is having an intermittent fever, and the rash is more in favor of the systemic onset JIA, sir, and the child is also having right-sided cervical lymphadenopathy associated with bilateral inguinal lymphadenopathy. Yes, sir. Those were the features I consider. And also, the child is having a oligoarthritis, sir. Which
so oligoarthritis. So is the systemic onset type, is the arthritis a major feature or it's a late feature? Arthritis is common. Is it common to have it initially with systemic onset type?
No, sir. Initially, the patient has an arthralgia, and then they get arthritis.
Yeah, if they get fever, high fever, is that a systemic onset type? Because systemic onset type, there will be high fever and they'll be very ill, loss of appetite, loss of weight, and then fearful always, and they'll have generalized lymphadenopathy, there'll be fallow, and there'll be hepatosplenomegaly. There can be serositis like pleural effusions, pericarditis, ascites, right? And then arthritis may not be there at all sometimes, right? So it comes as a PU sometimes, pyrus of unknown origin. PU may be not there at all, and the arthritis may not be there at all, and might be a later date presentation. So this child, the arthritis was there from the beginning, and there was 3 joints involved in initial phase, and large joints are involved, right? So with that, I know I don't mark you down for telling it systemic onset. There are features of systemic onset, but there are features of other types as well, right? So if you go by the number of joints involved, what do you call this?
Sorry, sir.
If you go by the number of joints involved in this child, what category will you call it?
Oligoarticular juvenile idiopathic arthritis.
Okay, oligoarticular. So what is the definition of oligoarticular? What is the definition?
Up to 4 joints. Less than 4 joints involved.
Less than up to 4, right? Up to 4. No, not less than 4. Up to 4. Up to 4. 4 or less joints are involved is the oligoarticular type. So can we categorically say this is oligoarticular?
No,
are you sure about why we can't be sure about it? Definition of oligoarthritis. What is the definition of oligoarthritis?
It should be up to 4 joints. The child is only having 3 joints involved.
Right, so it's all right. So
Okay.
also less than 4, no, right? Okay, up to 4 joints during how much what period?
6 months, sir.
Yeah, during first 6 months of illness, right? So with the onset of disease, during first 6 months of illness, if less 4 or less joints are involved, you call it a oligarticular type JIA. And this child history still about only 1 month.
1
Isn't
month,
it?
sir.
1 month, right? So
Yes,
if
sir.
he develops about 3 or more joints, no, some more joints, maybe 5 or total 5 or 6 joints involved during next couple of 5 months, then it become a not a oligartical type, right? Understood. So still we can't say it is oligarticular, but apparently looking at the picture, it sounds like more like it's going to be oligarticular because now for the 1 month period, it has been static on 3 joints. Right? So,
Yes.
can we categorically diagnose GIA as well here? Can we definitely say it's GIA?
Yes, sir.
What is the lacking in here? Because the definition on your board
Yes.
now. Can you see all of you? Can you see this slide? The definition. Definition of GIA is chronic arthritis lasting for more than 6 weeks in a child less than 16 years old without definite identifiable cause. Right? So this child history still about how much? 4 months. Right?
4 weeks.
4 weeks. So according to definition, the arthritis should last for 6 weeks to make the diagnosis. But you don't see what bottom line has written it, but you have to wait for 6 weeks to diagnose, right? So that is the confirmation that is JI, not so it's not an acute thing. That's why it's say, right? So you don't have to wait and treat for 6 weeks. Let the child to suffer for 6 weeks before you make a diagnosis, right? You can diagnose it earlier, right? But by definition, it's up to 6 weeks, right? So it is why do you call it 16 years it is it's called juvenile. Juvenile can more than 16 years now you call it a rheumatoid arthritis, like in adults. Right? Idiopathic you can't find identify definitely other autoimmune condition that could result in arthritis. Right? So juvenile chronic because more than 6 years and right? So that is the definition of it. So how will investigations help you in making a diagnosis of JIA? How will you investigate a child? If you are the patient, HO who received this patient on admission, how would you have investigated this child?
First, sir, I will do the initial investigations like the full blood count, looking for high WBC counts and high platelet counts. Then I will do ESR
what
and
will be
CRP.
hemoglobin? Hemoglobin
will be low, sir.
Low. What's the reason usually get anemia? GIA? It's a mixed thing, but main reason is macrophages. Macrophages tend to trap iron, right? Macrophages are activated, no macrophages tend to trap iron. Inflammation, in the synovium, the macrophages tend to trap iron, and then iron is not available for hemopoiesis, and then there is direct toxic effect of bone marrow with the inflammation. It's multifactorial, but these are two important factors. One thing is bone marrow suppression due to toxic effects, and other thing is iron being trapped in macrophages, right? Okay, so there can be anemia, and white cell count will be WBC will be
high, sir.
High, you said, no? Differential?
High.
What differential? Differential count? What will differential count? Lymphocytic or neutrophil?
Neutrophil leukocytosis.
Yeah. The neutrophil leukocytosis actually marginally elevation or very high elevation? Very high elevation, right? Okay. And then platelet count will be high. Why platelet count is high?
Uh,
Any chronic inflammation can cause platelet count to go up, right? So that's a
okay, sir.
like in even in the Crohn's disease, right? Any chronic whooping cough, right? Any chronic inflammatory process
Okay,
will cause platelet count to go up, and you can use platelet count as an inflammatory marker as well, right? So, as a feature of relapse, you can use the platelet count. If the platelet count are rising, that indicates the child is going to a relapse, right? So, if you do you want to do only the full blood count? Do you want to do anything with that blood sample?
blood picture.
Yeah, good. Blood picture. You do a blood picture. So, what do you expect in the blood picture to see? In child with JIA, especially in a child with systemic onset type.
Mm,
Especially neutrophils, what do you expect to find? There will
not
neutrophil
sure, sir.
leukocytosis. There will neutrophil leukocytosis. What else? What else about neutrophils? Anybody in the group? Anybody? What will you find in neutrophils? The blood picture. There will be left shift and toxic granules, right? The left shifting means what? What do you mean left shifting on neutrophils? What the meaning of that word? Left shifting? What is left shift?
Immature forms are present.
In which form or how? Which? Why? Yeah, right. But what is left shifting means actually? How many lobes are there in neutrophil? Nucleus?
3 to 5.
Yeah, 2 to 5. Actually, 2 to 5 can be there. 2 to 5. Right. So, does the number of lobes increase with aging or decrease with aging on neutrophil? Number of lobes, do they increase with aging or do they decrease with aging? Number of lobes in a neutrophil.
Decrease with aging, sir.
Increase with aging, right? So, more age the neutrophil, there are more lobes. So, if you have more newly formed neutrophils in the circulation, there's an increased demand and bone marrow puts out a lot of neutrophils out in circulation, then what do you expect to find? Less lobulated neutrophils or more lobulated neutrophils? Less lobulated. So that's what we call left shifting, right? So there will be more neutrophils with 2 or 3 lobes rather than normal 4 to 5 lobes, right? That's what we call left shifting. And other change you see in neutrophils when there is increased production of neutrophils, sudden production and putting it out. Similar thing we see in septicemia or acute inflammatory conditions. You see this when bone marrow is putting out a lot of new neutrophils. One thing is left shifting, but other thing. Anybody? What other feature in neutrophils you see when there is increased production of neutrophils on the bone marrow? What the neutrophil contain apart from nucleus? Granules, yeah, right. So what about granules in fresh neutrophils compared to old neutrophils? Compared to old neutrophils, new neutrophils have less granules or more granules? What is granules? What does the granules contain?
Lysosomes.
Yeah, the enzymes. The enzymes involved in the oxidative phase that involved in destruction of the phagocytes organism. Right? So with time, the enzyme levels go down. So the newly formed white cells, neutrophils will have more amount of large granules, right? Large granules stain very strongly. And what do you call them? What granules?
Acidophilic granules.
What you see in blood picture in a child with JIA is neutrophil leukocytosis with left shifting and toxic granules, right? So when you see this, whenever you see this left shifting of neutrophils and toxic granules, that indicates high swinging fever, hepatosplenomegaly, and you get this white cell count high. What is your differential diagnosis? What do you think of? What's
Syndrome, sir?
there was a connection problem. Sorry?
Syndrome.
Not
Macrophage
syndrome.
activation syndrome, sir?
Acquired syndrome make it common thing. Yeah, it's a fatal condition. I think of that. There's a palo and all those things, but generalized lymphadenopathy, high fever, it's not that common acquired system syndrome. What do you think? Any child coming to you, say a 3-year-old child coming with high fever, you find him to be pale, and there's generalized lymphadenopathy, and there's rash.